This is a short presentation on a few concepts in head injury. Various subtopics in head injury, starting from epidemiology to pathophysiology, the clinical profile, imaging modalities and their relevance, clinical and intracranial pressure monitoring, on biochemical markers of TBI, medical management, surgical management, outcomes and rehabilitation. We are today going to focus on some aspects of the pathophysiology of traumatic brain injury. Lecturing on head injury seems to be a hobby. I gave my first lecture on head injury in 1983 as an intern for nursing students. There are multiple presentations and some papers, most of the papers being in the Indian Journal of Neurotrauma, Indian Journal of Surgery, and in the Marine Medical Journal. There are also some papers on spinal cord injury and in the various modalities, including stem cells in spinal cord. Brain injury in combat, it is military traumatic brain injury, is a subject on which I have a special interest. However, that is another topic. We'll talk about it sometime when we have time. A few anatomical considerations when we talk about traumatic brain injury. The cranium is a box in which the brain is housed. The location of the brain and the mobility the cervical spine offers to the brain has philosophical connotations. If God just wanted our brain to be protected, I'm sure he could have kept it in the pelvis. But the location in the cranium, our brain has to be open to ideas. We have to explore. It gives the brain a location from where which it can see the world and respond to it. The box has got openings, starting from minute openings in the cribriform fossa, through which the olfactory fibrils get in, to larger, and the largest being the foramen magnum, through which the spinal cord exits, and the posterior circulation blood supply comes in. The brain has got coverings, a tri-layer covering for protection. The outermost covering is the dura mater, which translates into durable mother in Arabic. It has got a firm outer covering which is adherent to the periosteum, and an inner covering which is inner layer which actually provides partitions. These folds, there is a central vertical fold called the falx cerebri and a horizontal fold, the tentorium cerebelli. These partitions have within their folds venous sinuses. The partitions also serve as movement restraints. We turn the head from side to side. Torsional injury to the brain would be prevented by the falx, which prevents rotation of the brain. And also the tentorium cerebelli protects the brain stem and the cerebrum in anterior-posterior movement of the cerebral hemispheres, which are heavy, which would otherwise compress the brain stem. Inside the dura, we have a fluid-filled envelope, the arachnoid, a transparent membrane, which encloses CSF, cerebrospinal fluid. The innermost layer of the meninges is the pia, which is like a cling wrap. It dips into the crevices of the brain and it dips into the VR spaces around the vessels. So that through this pial envelope, we are having cerebrospinal fluid, which can sort of numb or null the pulsations of the vessels within the brain. The brain itself has the outer layer, which is mainly made up of neurons and the supporting astrocytes. The astrocytes were initially considered to be the bricks and mortar which held neurons in place and also nourished them. Now the concept has changed a bit. We know that astrocytes are more than that, and the glial syncytium has got a role in brain function which is still being explored. White matter consists mainly of axons with the oligodendrocytic linings. These prevent lateral transmission from the uh, axons. Synapses, where neuron meets neuron through the axon or dendritic synapses, are points of information transmission. They are also important. They are also very important in coding of information and also in archival, because finally information is saved initially in the synaptic maze. The cerebrospinal fluid is critical for brain protection. It supports the brain, it floats the brain. The brain floats in a small bucket of CSF, because if the brain were to rest on a hard surface, it will get crushed under its own weight. The CSF circulation, we all know, we want quick revision. Choroid plexus is secreted into the ventricles. CSF from the lateral ventricle go through the foramina of Monro into the third ventricle, then through the aqueduct of Sylvius into the fourth. Communication with the central canal of the spinal cord is usually partially or completely blocked. And then you have fluid exiting from the fourth ventricle through the midline foramina of Magendie and lateral foramina of Lashka. CSF flows through cisterns, which are actually cushioning the brain also, and through the cisterns, through the subarachnoid space, and gets absorbed into the venous sinuses through arachnoid granulations. The blood supply, quick revision, anterior circulation from the carotid system. The internal carotid arteries divide into anterior cerebral and middle cerebral. Two anterior cerebral arteries communicate with each other by the ACOM, and then the posterior circulation from the subclavians through the vertebral arteries, which unite inside the foramen magnum to form the basilar, gives off posterior inferior cerebellar arteries, anterior inferior cerebral arteries, and then divides into two posterior cerebral arteries, which communicate with the internal cerebral artery through the PCOM, or the posterior communicating, forming the circular villus. The venous system, superficial and deep, drains through venous sinuses into the internal jugular vein. Coming to the pathophysiology of injury, injury mechanisms can be impact, inertia, perforation, or missiles. Impact is at the surface. The head hits a hard surface or is hit by a hard object. The skull is impacted. The brain is impacted just under that, and then you have the co-injury. The brain bounces back and hits a point diametrically opposite, producing a counter coup or a contrary co-injury. Injury to the skull results in fractures, which might be depressed or simple. You can have bleeding outside the durameter, which is called an extradural hematoma, which can be from the fractured bone or can be from the dural surface. You have bleeding from the brain surface, producing subdural hematomas under the dura. This can be either from the surface of the brain or by rupture of vessels or veins which are passing from the brain surface to the venous sinuses. Traumatic subarachnoid hemorrhage is a small bruise on the brain surface with blood contained within the arachnoid. And then contusions are actually bleeding into the brain surface and in between the neurons, resulting in a mixture of blood and brain, which produces a salt and pepper appearance, which we will be talking about later. That is impact injuries. Inertial injuries are because of distortion, acceleration, deceleration injuries. Vessels can rupture, producing intracerebral hematomas. Axons get injured. That is the main inertial injury. In fact, diffuse axonal injury is the characteristic inertial injury. Axonal stretch can produce various grades of axonal injury. Firstly, the severity. It can be just a conduction block. An axonal stretch does not conduct. After some time, there is restoration of physiological conduction. Disorganization of the internal cytoskeletal network can occur without an actual rupture, which sometimes produces a manifestation where axons seem to be protuberant in places called axonal varicosities. The most severe axonal injuries are axonal ruptures, where the ruptured axon actually retracts to form what is called an axonal retraction bulb. Axonal injuries are also graded based on location. There is a more classical radiological classification of diffuse axonal injury. You can have axonal injuries at the gray-white junction. Axonal injuries can occur near the corpus callosum, that is grade 2, and in the brainstem, where it is considered more severe and called grade 3. However, grade 3 axonal injuries are not as dire as sometimes what we think, because you can have brainstem bleeds without having very major deficits, totally different from the Durett's hemorrhages, which are associated with herniations. Sequelae of inertial injuries, loss of consciousness because of stretch of axons within the brainstem. It can be very severe, result in coma, or it can be even minor when the patient wakes up soon. Minimally conscious states and lockdown syndromes are also because of axonal disconnections, of severe axonal disconnections of the cortex. Sequelae of missile injuries, injuries along the tract. A missile injury which passes through the core brain is associated with a very poor prognosis. Blast injuries are the signature injuries of today's war. You have multiple axonosynaptic disruptions, which are similar to inertial injuries in their manifestations, but with a different mechanism. Sequelae involve seizures after recovery, and they can also develop post-traumatic stress disorders. Here, I just like to introduce you to a concept of reflexes called the thalamic reflexes, where some sensory inputs, which are not generally sensed at the thalamus level, can result in the triggering of a reflex. For example, a visual, something which is, a stone hurtling towards your head, which you see, might cause you to duck without even cognitive processing. You don't think whether it's a stone or what it is, but you still duck. Or a sound in the background makes you jump. These are all thalamic reflexes. So thalamic reflexes may be associated with an element of amygdala activation also, which can result in severe fear. And some of these patients returning from war zones have evolved thalamic reflexes, which might manifest even in inappropriate places. Chronic traumatic encephalopathy or punch-drunk syndrome is a syndrome of recurrent head trauma, as you can find in boxers or even in some football players who keep heading the ball, which can result in a phenomena which are akin to Alzheimer's, so where there is chronic neurodegeneration. All head injuries also have a hypoxic component. This might be just because of transient apnea, because of airway blockage, because of hemorrhagic shock, because of associated injuries, because the patient might have a transient cardiac arrest with transient arrest of blood flow to the brain, or just because of choking on vomiters or by a foreign body. Hydrostatic edema is a term which is used to define the increase in the fluid content within the brain, which occurs because of a blockage of CSF pathways. Tension pneumocapillus is rare. We have to talk about inflammation, inflammatory and apoptotic cascades. Inflammatory cascades are triggered off after head injury, which compound the neurological injury. Activated macrophages enter the brain interstitium, producing further inflammatory cascades. Apoptotic cascades involving caspases will result in continued neuronal damage long after the actual injury is over. Secondary injury also involves herniations. Herniations, the primary cause are hematomas, because one side there is a hematoma, it pushes, or one chamber there is a hematoma, which pushes the brain across to other chambers. So these herniations can be produced by hematomas, as we said. And where do the hematomas occur? Hematomas may be extradural, usually lenticular in shape, usually associated with skull fractures, but in children can occur even without a skull fracture. Skull fractures across vascular markings are especially prone to produce extradural hematomas. And extradural hematomas may not be associated with primary brain injury because the brain is not significantly injured. However, blood collects in the extradural space, increases in size, and produces herniation, which results in a secondary brain injury and often death. Subdural hematomas are crescentic in shape. Bleeding, like we said, occurs from surface vessels or from bridging veins. Usually, subdural hematomas, because the brain is injured directly, is associated with a element of cerebral edema. So here you see a brain which is shifting, a midline shift for a subfalcine herniation, which is occurring. And here you have a subdural hematoma with a certain thickness. This SDH thickness by midline shift ratio gives us an indication of the degree of brain edema, which is actually an index of the severity of brain injury. So an SDH, if it is corresponding directly to the midline shift, then you can say that cerebral edema is not much and the patient's prognosis is better. However, SDH of 2 millimeters with a midline shift of 6 millimeters might suggest significant brain edema and probably a poorer outcome. Confounders here are contralateral injuries which prevent the midline shift from increasing. And also, nature has got a protective mechanism to prevent a midline shift. That is, when there is a mass in one hemisphere, the foramen Monro gets kinked, and this results in the contralateral ventricle getting distended, preventing a further midline shift. This is often seen on CT scan as a contralateral lateral ventricular dilatation in a patient with a mass lesion on one side. Intracerebral hematomas are spheroidal in shape. Contusions have got a salt and pepper appearance. That is mixture of neural elements along with blood. Traumatic subarachnoid hemorrhage usually does not produce much mass effect, but it just shows that the brain is injured. As you said earlier, there are many types of herniations. You can have a subfalcine herniation. Usually the cingulate gyrus, the medialmost gyrus of the frontal lobe, herniates under the forks to the opposite side. You will have a foramen Monro kinking, contralateral lateral ventricular dilatation. You can also have an anterior cerebral artery which is getting blocked, resulting in a contralateral leg weakness. The more classical herniation is the lateral transtentorial herniation, where the uncus of the temporal lobe herniates through the tentorial hiatus. This will press upon the midbrain, especially the corticospinal tracts of the midbrain, producing contralateral hemiparesis. The third nerve coming from the pons to the cavernous sinus will get pressed. The parasympathetic fibers coming from the Edinger-Westphal nucleus, which travel along with the third nerve, get pressed, resulting in ipsilateral pupillary dilatation. The posterior cerebral artery can get occluded, resulting in an occipital infarction and loss of the contralateral visual field. The next type of herniation is a midbrain descent, when the pressure is bilateral. And this produces a distortion axonopathy. And one of the manifestations is a Cheyne-Stokes breathing, along with, of course, loss of consciousness and deep coma. Foramen magnum herniations will result in cardiorespiratory failure. These patients also have ataxic breathing called medullary ataxic breathing, and they have hypotension. Now, up to now, it was standard teaching. Now we talk about a few things which are not fully understood. Consciousness, loss of consciousness. Why do people lose consciousness after head injury? It is because of stretch of fibers within the brainstem. The brainstem is the seat of consciousness. The thalamus, people say sometimes, is a seat of consciousness, but actually it is a seat of awareness. The brainstem puts the switch on, and then the thalamus starts processing sensory information. Memories are stored in the hippocampus temporarily, it's a desktop, and then archived for long-term keep in the neocortex, in two zones actually. One is the frontal lobe and then the other is the association cortex. Let's have a quick look as to how we record a memory. Humans are visually dominant. A visual impulse passes through the optic nerve, through the optic chiasm, through the optic tract, and reaches the lateral geniculate nucleus. Most visual impulses are not sensed at the thalamic level, but some hazard impulses might trigger off a reflex at that level, which can result in a protective maneuver. Then, from the thalamus, we have optic radiations going to the occipital cortex. The occipital cortex sees the lines, the outlines, and then images pass on to the visual association cortices, which are adjacent to the occipital cortex, where images are recognized. Now we have filters. If the image is significant enough to be recorded as a memory, it passes on to the hippocampus. At the hippocampus, there is multimodality integration, the different aspects of sensory input, the visual, the auditory, the olfactory, everything is merged to produce a memory sachet. Now this is preserved in the desktop till a convenient moment when it can be moved to the neocortex for long-term archiving. This moment occurs during shortwave sleep, known as SWS sleep. Two trajectories for memories to be recorded. Memories go to the frontal cortex, where actually a memory is stored in language form. It is a gist of the memory. And the second is in the association cortex, where you have multi-modality memory archival within neurons. So this is a secret of human intellectual superiority, because the memory stored in gist form can be easily manipulated and easily. So you have access from the frontal memory gist store to the memory repository in the neocortex through the caudate nucleus. So the frontal neocortex is storing gist information where executive decisions can be taken, and the supportive information comes from the association cortices. Memories in the hippocampus are synaptic, and as they move on to the neocortex for archival, you have intraneuronal information repositories. The exact mechanism of memory storage inside a neuron, postsynaptic, is not well known. However, possibly DNA chains and epigenetic strands record the information. You have single neurons registering a concept. Movement of memories from the synaptic maze to intraneuronal repositories occurs during REM sleep, and that is when dreams occur because of a churn of stored memories. Moving on, discussion on the function of the brain, because functions are lost after head injury. What is intelligence? Intelligence is the ability to assimilate information, to process it, and to act upon it. All life is intelligent. A plant is intelligent because its roots seek out moisture. It projects its leafy foliage to sunlight so that photosynthesis can occur. Unicellular organisms are intelligent. It moves away from a toxic stimulus and towards nutrition. There are some special features of human cognition. Information within the brain is both inherited and acquired. You are born with a certain amount of information. You are born with information which is species specific. The way a child cries, the way a child gropes for the mother's nipple, all those behavioral patterns are ingrained within the genome. There are some predispositions within families and also parents. The phenotype is well known. Tall parents have tall children. But even the cognitive types do intelligent parents have intelligent children? Yes, to a certain extent, these are inherited. Some of these are templates. Most of them, in fact, except for a few basic pre-written codes, are templates. These templates will function once the information is coded on the template. But the templates can evolve. Decades, multiple generations of trees might give progeny who have more priestly disposition and more ability to learn what the priests have to learn. So templates evolve over a period of reverse transcription. Musicians, generations of musicians, after some time, the children have more capability to learn music. Now, this education of this template can be either structured and unstructured. Unstructured is from the environment, and structured is by the formal education process. Assimilation of information is selective and it's sequential. You cannot learn calculus without learning your basic mathematics. The second is knowledge. What is knowledge? Knowledge is information which is matured by application and by feedback. And what is wisdom? Wisdom is knowledge which is tempered with values. A few words about recovery from brain injury, the pathophysiology. How do we recover after a head injury? Firstly, when the metabolism of neurons restarts and conduction along an axon restarts, you have recovery. This corresponds to metabolism kicking back, also with cerebrovascular reactivity, there is autoregulation coming back. Very often in a patient who has got a decompressive craniectomy, the subsidence of the swelling is less because of cerebral edema and more because the cerebrovascular reactivity has been restored. Blood-brain integrity is restored, membrane pumps come back, metabolic restoration, all these result in restoration of function of viable neurons. The second is repair of the axonal microskeleton. That can result in axons functioning again. If an axon is completely lost, some of the functions of the neurons it supplies occur because of new synapses, neosynaptogenesis, reconnections. These can sometimes result in delayed awakenings of people after prolonged coma. In an injury where there is diffuse axonal injury, some cortical islands may have preserved information, and reconnections can result in near complete restoration of some memories and skills. Plasticity involves some areas of cortex which are damaged, the functions being taken over by other areas of cortex which are not damaged. Plasticity is more manifest in the younger age groups. Then, of course, we have neurogenesis. Stem cells are present in the subendothelial layer of the ventricles and in the basal forebrain. These are actually embryonal cells which can divide, differentiate, migrate, and integrate. However, restoration of function by stem cells is suboptimal, to say the least. Most of the restoration is by plasticity, not by neurogenesis. The human brain is the crown jewel of the universe. We cannot understand brain trauma without understanding brain function.